Hello and welcome to this edition of Central Connecticut Now, the program that brings you closer to the newsmakers of our region and the people that cover them for the media. I'm Mike Schroeder, publisher of the New Britain Herald and Bristol Press, and today my guests are Kurt Barwis, President and CEO of Bristol Health, and Dr. Andrew Lim, Medical Director for Emergency Medicine at Bristol Health.
Thank you.
Welcome, gentlemen. And today's subject, we're going to be talking about something that's on everybody's lips these days, as well as their hands too. Oh yeah, that's right. The virus, the virus, the coronavirus. What else is there?
Yeah.
But we're going to find out that it's not exactly new. And one of the things that we just came away today from some announcements from the state talking about their preparations, and you seem to be right up there.
I don't know if I'm right up there, but I was with the state today, and thank you, Mike, for doing this. This is a very important program for the community. The coronavirus, which we call COVID-19 for 2019, I guess is when it started. Not here, but anyway, is on everybody's minds, like you said, and what I think the public needs to understand. There's a lot of takeaways for them, and hopefully we get the message out to them today. But I think more important, is to know how prepared we are. I mean, now we can't anticipate everything, but we are certainly working together with the administration of the state, through the Hospital Association, CDC, American Hospital Association, and really partnering to try to bring the best practices to Connecticut to make sure that we minimize, to the best extent possible, the impact of this terrible virus on Connecticut residents. And
one of the things that get confusing is the naming of this thing. I mean, you see all kinds of variants of the virus. Can you speak to that a little bit, Dr. Lim?
Of course. So coronavirus in itself is not completely new. Coronavirus is actually the common cold. So coronavirus has actually been around for many, many years. Now, the challenge is that this novel or this new coronavirus that we discovered in 2019 has mutated. So the difficulty is that there is no immunity to it. There's no vaccine, and there's no specific antiviral. I know initially the mortality rates were estimated to be about 2%, which was quite worrisome. But I think there's a lot more emerging data to suggest that the mortality rate is actually going to be more similar to the flu, which we are all used to, and actually be less than 1%. And to kind of put that in perspective, some of the other diseases that have come across the news, such as Ebola. Ebola has a mortality rate of 50 to 70%. SARS has a mortality rate of 10%. So, I think with new data coming out, obviously anything new or any new pandemic is scary when you don't know. But I think that there's a lot of good sources now think that this will have a mortality closer to the flu.
Are we now at the point where we can safely say this is a pandemic?
I knew you were going to follow up with that question as soon as you said it.
Yeah.
I know everybody seems to be on the fence,
sure.
At least at this point in time.
Sure. I think there's general consensus that we're moving towards the realization that we need to do what we can to contain it. I think the realization is that we can't stop the spread. But I think, especially in the United States, we've been aggressive about trying to contain outbreaks and doing a good job about that. I think we have the benefit of seeing what has happened to other countries in China, in Europe, and trying to make public health policies that make sense to try to restrict the big outbreaks here.
Now, do you expect us that this is going to be a continuing issue for us? You hear almost nothing about Ebola anymore.
Sure.
You don't, SARS, I haven't even heard until for years before now again.
Of course, yeah.
As a history kind of thing. Should we expect the same from coronavirus?
So I've heard a lot of interesting theories that because coronavirus is similar to the the common cold is similar to the flu. This may improve with the warmer weather, but I think there are some interesting theories that this may be a seasonal event where we may be talking about the common cold, influenza, and coronavirus. But I think, I think the point at which we'll start to gain some ground on this is once we start to vaccinate, and once we start to develop antivirals, is when we can start to push that back.
Any idea what kind of time frame you could expect on that kind of development?
All I know is from what I hear in the news,
Yeah.
and from what I see published, it's months to over a year out.
Yeah. Okay,
Yeah.
so it's possible that this could die out and come back the next midwinter season.
That's
Or not.
That's a possibility. That's a possibility. It's also possible that it may not. I think if it does behave similar to the flu or the common cold, I think the people who are optimistic will say that it will die out during the warmer summer months.
And what are you preparing for at the hospital? What efforts are you making,
of course,
to prepare for this?
Yes.
For any eventuality, which seemingly is what's expected of a hospital these days.
Sure. So I think the general saying, prepare for the worst, hope for the best. I think we've adopted that principle, but we do have daily meetings at the hospital, pulling in directors from multiple departments and specialists from infectious disease. We pull in our hospitalist partners as well too, to really, with the overall goals of making sure that we can be in a place to provide for our patients, really in a safe manner, to making sure that our staff are protected and cared for, but also planning for what we anticipate is an increase in volume. And finally, also being able to be a resource for the Bristol community, making sure that we can continue to be a resource for our outpatient community docs as well too. So every policy that we make and every communication that we have on a daily basis with our teams really has those goals in mind. The challenge is that we take a lot of our cues from the CDC, from the World Health Organization, from other area hospitals and other specialists, and the data that we receive and the recommendations that are made are changing on a daily basis. So that's why meeting on a daily basis is so important, and trying to stay on top of the new information that comes out.
Now, you've prepared some very specific ways for isolating possible victims of this illness. Can you talk to us a little bit about that?
Of course. So we refer to those patients as a patient under investigation, or a PUI.
Okay.
Essentially meaning someone who we're suspicious that has the virus and that we're going to test for. So we've drawn
persons of interest.
Persons of interest.
Medically speaking.
Persons.
Exactly. So essentially, we've taken cues from the CDC as to how to screen appropriately for someone who has risk factors. And essentially what we're doing is we're asking that our front-end staff, whether that be a triage nurse or an ED technician, at the front entrance, ask those important questions. So, I break that down into, do they have demographic risk factors, and do they have clinical symptoms that make them at risk? So have they traveled to an area of outbreak? But of course, the challenge of that is that that's evolving, right? We are learning about new areas of outbreak every day. Another risk factor that we ask is, have you had close contact with someone who is under investigation for having COVID or has tested positive? And once again, that's the challenge in that, is that when you work at a big company, you're exposed to a lot of people. And many of those people have flown around the world. So how do you know, and what constitutes a close contact as well, right? So, and the second part of that is, do you have a fever, a cough, congestion, symptoms consistent with an upper respiratory infection? So when we identify those patients, we're quick to act to isolate them. Ideally, we don't want them waiting in the waiting room. We want to bring them in immediately. And we actually are able to set up a special isolation room that has negative pressure, with the idea that if this is spread by airborne droplets, that we can safely place that patient in that room without any chance of spreading their illness.
So you contain the issue.
Correct.
The one thing that keeps coming up are masks.
Sure.
You know, how effective are they? Should you use them?
Yep.
Should people that have some kind of illness use them, or is it protecting it from getting it from those?
Of course.
Can you tell us a little bit about who should use masks, who shouldn't, and do we have plenty of them?
Okay, so that's a loaded question. But, so in this, I'll kind of go back to so in the situation where we've identified a person who we're going to test for coronavirus, we immediately put a mask on that patient. In a situation where we've identified someone who's going to be tested or our level of suspicion is high, we've instructed our staff to use protective equipment to protect themselves, what we call PPE, or personal protective equipment. In that setting, we're using the highest grade masks, what we call respirators or N95 masks.
Those are the ones with the little things in them, right?
Well, it has, the important thing is that it forms a tight seal around your face.
They say that it's important to be fitted correctly as it is to have the mask.
That's correct. That's correct. So they're different sizes, and and different. Everyone has a different shape to their face.
Yeah.
So it's important to get what we call fit tested through. We use MedHelp and MedWorks to make sure that every employee at the hospital has had recent fit testing, especially for a situation like this.
Oh wow! So everybody at the hospital has been fitted for a mask, one way or another.
Correct.
Okay.
Patient care folks have been fitted for a mask.
Okay.
Like I haven't been fitted for a mask. Should I be fitted
Because
for a mask?
Yeah, you can participate in some patient.
I do. I will help move the patient if I have to. So.
Yeah, everybody pitches in when you have to.
Absolutely.
And have we seen anything at this point? I mean, have you had people come into the hospital say, I really want to get tested, or even for no good reason?
Well, I will say that we have tested some folks. We do not have any positive cases. In central Connecticut, thus far, there are no positive cases. As of right now, the one positive case was in Fairfield County.
As of March 8th.
Correct, yeah. But I will say we have a heightened sense of suspicion, and we screen when appropriate. So that being said, if a patient comes in and wants to be tested, it starts a dialogue. I think we need to evaluate their risk, and like any other test in the ER, whether it be someone who comes in with requesting a specific test, that leads to a discussion between the physician and the patient, and many times it's appropriate, but sometimes if it's not appropriate, it's our job to explain why that test is not warranted or why that test should not be done. So the CDC guidelines have recently widened to add in physician discretion into that protocol mix. So that's kind of where that comes in.
Mike, I'm going to interject here. So if you think you have the symptoms that Dr. Lim just talked about, you should call your primary care physician, because the last thing, remember, we don't just have patients coming to the ER that are suspected COVID-19 patients. We have all the other patients coming in. And so what's really important to understand, what the key takeaway here is that if you think you have these symptoms, as Dr. Lim talked about, upper respiratory symptoms, coughing, fever, those kind of things, the first thing you do is call your primary care physician. That's the first thing. Because if it's simply you're not sure, you want to go through that with your primary care physician. If they think you need to be tested, then that's where you would come to the hospital. They would make that triage call. We want to make sure that's clear, because what we don't want to do is get overrun with people that just say, I think I need to be tested.
That's a good point, is at what point do you, most of us don't call even our doctor for, we got a little sniffle or we got those kind of things. Should we step that down at this point in making the call to the primary care doctor? I mean, if we get a runny nose, should we be really considering a
It's
call?
more than that, right? I mean,
Yeah, so you ask a good question, and what I would say is that in the current state that we're in, it's so important to be on top of diagnosing and figuring out who may have the virus to help prevent spread to others. So I think in the current environment that we're in, if you're sick but don't think you need to come to the hospital, absolutely, I want that person to call their primary care doctor to help assess the risk for having coronavirus. That being said, the vast majority of people who get diagnosed with COVID-19 actually do just fine. I think there's some reports that 80% stay home and never need any intervention, never need to go to the hospital, never need to get seen by their doctor, and they recover just fine. So for those people who realize that they're at higher risk because of recent travel or because of a possible exposure, a great resource is also the local health department as well too. They've been instrumental in assisting us at the hospital in terms of determining who needs to be tested and who needs to be screened. But they've also offered their services to the, as they should, to the public as to helping determine if they need to step it up, if they need to get tested or get swabbed. Part of the benefit of reaching out to your primary care doc is that if your primary care doctor decides that, yes, you do need to go be screened, we can then have time to appropriately set up the resources that we need in that situation, and have the correct expectation when you hit the door, where we can bring you in immediately and put you in an isolation room as appropriate. Which brings us to kind of our next point, that at Bristol Hospital, one of the things that we're looking into is kind of an alternative testing facility, where in a situation where if a primary care doctor deems it necessary to write a prescription to be tested, where we can do the swab in a safe environment in an alternative site, not within the walls of the hospital, get the test done, and discharge the patient like you would any other outpatient test.
Wow. So it really segregates it from the main hospital.
Correct.
Entirely.
Yep.
Both physical and all the people there.
Correct. And I think in something, in the situation that we're in, it's so important to have to be able to separate the population who may be infected with a contagious virus away from patients who don't.
Now, also at this point, there's always the question of the availability of test kits.
Of course.
Now, do you guys have test kits, or do you order them? What's the process?
Sure. So I think so the test kits reside with the state lab in Connecticut. So the logistics are that we have the swabs are pretty generic, the swabs to do the test, but no hospital has the kind of chemicals or the way to process that test. So when we perform the test at the hospital, we're able to collect the samples, but then those samples need to be sent as quickly as possible on ice to the state lab.
I see.
So that's the challenge. To this point, every patient that we've needed to test has been those samples have been sent to the state lab with no issues.
How long does it take to turn over a test?
Typically 24 hours.
Okay.
Yep.
And it's the incubation period, I believe, is like 2 weeks.
I believe. I mean, that's with some of the limited data that we've had so far.
We're still not sure of a lot of things yet.
Correct. I know that's kind of the kind of isolation period and monitoring period is based on the belief that it could be 2 weeks in terms of the incubation.
Can we review what people should do during this time
Absolutely.
to make sure that they don't get it?
Absolutely, absolutely. So, a lot of I get asked this question by many of my friends and family, but really a lot of the things are just basic hygiene, right? So just making sure to wash your hands with soap and water for 20 seconds, making sure to use an alcohol-based sanitizer on your hands, making sure not to, really
Now, the
avoid
sanitizer should not replace washing the hands, though.
Correct.
Right?
I think there is some data to suggest that washing your hands with soap and water may be better, or at least equivalent to the kind of hand sanitizer. But also, avoiding physical contact. It's so natural to shake hands and hug and kiss, and I think unfortunately, with what we're dealing with right now, it's best to refrain from that. I know a lot of the public health initiatives that we're doing are kind of aimed towards preventing spread, such as avoiding large gatherings, right, when not necessary. If there's an alternative, such as using technology and harnessing video conferencing, I know that's been proposed as well too. I know that from a hospital level, we've instituted some very good policies about visitors as well, to basically help prevent the spread, and really for the safety of our community as well too, where the general premise is, if you're critical to the care of that patient, absolutely, we get it. But if you're not critical to the care of that patient, if you don't need to be there, it would be best if you stay at home. But especially if you have symptoms, if you have a cough or a cold, and really that's pretty much any time, even external to COVID or coronavirus. If you're sick, you really should stay at home.
And so, have you seen any changes in change patterns of visitors and activities at the hospital?
I would say yes. I mean, so what we're doing is not so unique, but I think we're talking about it because of what we're dealing with and the newness and uniqueness of coronavirus. We've instituted new visitor restrictions with influenza, like many other local hospitals. But I think we have become so desensitized to the flu because it's here every year, and we're used to hearing about it and dealing with it and getting our flu vaccines that we have been desensitized. But I think in this current in the current state that we're in, and there is a heightened understanding of why we're doing what we're doing.
So would you say you're seeing less family visits, or are they keeping their distance, or?
I would say that I would say that we are seeing less family visits, but I think the benefit is that when we explain to visitors why we have the policy and why we're doing what we're doing, there's a lot more understanding.
I think, it would be important to talk about the age cohorts too, the people that are most vulnerable. So I have seen a decrease in senior people coming to the hospital for visits, so it's not affecting, you go through the age, you're much better prepared to talk about the age cohorts than I am, but I think people I know that there's a lot of press about this, but I think it's really important to talk about it.
But there's also a lot of other divisions of the hospital that are more centered on seniors. Like Ingerman Manor and where those are also places that
we have very specific protocols at Ingram Manor and for home care hospice, all of those places. I mean, if there was to be, if we had an outbreak or we had a situation where there were multiple patients, we would look at things like, and talking to my peers around the country, different hospitals, some, and even in the state of Connecticut have said if, seniors that are typically in the older generation are more at risk, of having being one of the 1%ers than somebody that's younger. So some are curtailing their volunteer program. You could see us change our visitor policy again. It is, as Dr. Lim said, the rules are changing from CDC every day. When I was talking to him last Thursday, they made a change about absolutely having to have an isolation room, which isolation rooms are limited, and just any negative pressure rooms, right, where the pressure takes everything outside of the room. Now, when I was sitting there, they said it would be okay to just have a room that's a private room with a door on it. But anyway, it's, visitors, you're asking about visitors, seniors, people that are 70 and older that have other conditions, not a good idea to come into the environment.
But the best thing to do now is just keep your ears open for changes as things develop.
Yeah.
So, and we suggest you keep reading the New Britain Herald and the Bristol Press for the latest on the virus and everything else that's in the news, as well as Bristol Health.
Absolutely.
And we thank you for joining us on this program. CT Now will be back in another couple of weeks with some additional newsmakers and news gatherers. I'm Mike Schroeder. Have a great week.